The assessment of a child with calcium disorders requires a comprehensive understanding of physiology and pathophysiology and appropriate use of diagnostic tests in the appropriate settings. The key workup use the use of blood tests for calcium, magnesium, phosphorus and alkaline phosphatase along with urinary calcium and phosphorus, and I think these should be the basic tests which should be done in all children in which there is a calcium disorder which is suspected. Hormonal evaluation, particularly PTH and vitamin D, is done in many cases, while FGF23 is restricted to certain situations. Serum calcium level should ideally be done in the morning in a fasting state. The sample is a serum. There could be problems in the setting of hypoalbuminemia, wherein the total calcium may not be a good reflection of ionic calcium, and hyperproteinemic state can cause pseudo hypercalcemia. To correct for the effect of albumin, one can use the formula for corrected calcium. For every 1 decrease in albumin levels, we need to add 0.8 milligram per dl for the calcium level to get a corrected calcium. And similar correction can be done when we are using gram per liter for albumin into 0.02 in the setting of the SI units of millimoles per liter. As we all know that there is a significant dip which happens in the first 24 hours in the term as well as preterm neonates. The criteria for hypocalcemia is different for different age groups. So for individuals who are less than 1500 grams, 7 to 11 milligram per dl of total and 4 to 6 of ionic is considered to be normal. In neonates beyond 1500 grams, the cutoffs for hypocalcemia become more strict with levels between 8 to 11 and ionic 4.4 to 6 milligram per dl in this perspective. In the post-neonatal period, the cutoffs are even higher with range of 8.6 to 12 milligram per dl for total and 4.6 to 7 for ionic calcium. If you want to convert the milligram per dl to standard international unit, we need to divide it by 4 as 1 millimoles per liter is equal to 4 milligrams per deciliter. Serum phosphorus should again be done morning in a fasting state because phosphorus levels are affected by carbohydrate intake. It is a serum sample and we should be cautious that there should be no use of tourniquet or squeeze sample because that can falsely elevate the level of phosphorus. One needs to be very cautious in using age specific levels because phosphorus levels are higher in younger individuals. So in infancy, the levels are 5 to 8 milligram per dl, while in childhood the levels are 4 to 6. Unfortunately, most report that we are comparing, we get the adult cutoff levels of 2.2 to 4.6, in which hyperphosphatemia is inappropriately diagnosed. So one should always compare the phosphorus level to the age specific controls, and to convert the SI unit, which is millimoles per liter, to the milligram per deciliter, it is 3.2 times the level. Alkaline phosphatase levels are good marker of bone formation and bone turnover and particularly relevant in the setting of metabolic bone disease. They should be done in a serum sample. Alkaline phosphatase levels can come from the liver, bone and placenta. In most cases, they give good reflection of bone unless there is a liver disease in a child. They have a good indicator for osteoblast activity and bone turnover. The levels are very high in the setting of rickets and they may actually increase with treatment of rickets. High levels are also seen in the setting of hyperparathyroidism, while low levels in the setting of metabolic bone disease are seen in the presence of hypophosphatase. So alkaline phosphatase levels should also be interpreted with the age. The most common unit which is used is the international units per liter, and in children levels are much higher compared to adults to 200 to 600, while in adults the level are 60 to 170. And again, a very common reference which is given to the pediatric endocrinologist is because of high levels of alkaline phosphatase which are actually age appropriate in this setting. The standard international unit can be converted by multiplying it by 16.7. Serum magnesium levels are extremely important in the setting of hypocalcemia and hypokalemia because hypomagnesemia should always be considered in the setting of refractory hypokalemia and hypocalcemia, it should again be done morning in a fasting sample. Because it's an intracellular ion, we should be careful that there is no tourniquet used and there should not be a squeeze sample. The levels are 1.5 to 2.5 milligrams per dl or around 0.6 to 1 millimoles per liter. Assessment of urinary calcium excretion is important in various settings, particularly in the setting of hypocalcemia to identify the hypercalciuric variant, or in the setting of hyperparathyroidism to identify the calcium sensing receptor defect, or in terms of monitoring of calcium levels in various settings. It should ideally be done on a 24-hour collection, but often it is difficult in children, so therefore the second urinary sample for spot urine is considered. And the criteria for hypercalciuria include levels which are more than 4 milligrams per kilogram per day, and a urinary calcium creatinine ratio which is more than 2.25 milligram to milligram, and 0.7 millimoles to millimole is considered to be hypercalciuria. In the setting of metabolic bone disease, high urinary calcium is indicative of distal RTA, while low is indicative of vitamin D deficiency or vitamin D dependent rickets. High urinary calcium with low serum calcium should indicate a activating calcium sensing receptor defect, while low levels with high calcium should suggest a calcium sensing receptor inactivating defect causing hyperparathyroidism. Urinary phosphorus excretion is also important, particularly in the setting of rickets where the possibility of hypophosphatemic rickets is concerned. This is done using a calculation of a fractional excretion of phosphorus, which is basically urinary phosphorus upon plasma phosphorus divided by urinary creatinine and plasma creatinine. Then a tubular resorption of phosphorus is calculated by subtracting FePO4 from 100. The normal range in children is 85 to 97%. But what you need to remember is that the tubular resorption of phosphorus is highly dependent upon the plasma phosphorus level. Therefore, another formula or another measure which is used to assess actual phosphorus excretion, which is independent of the GFR or the phosphorus level, is the tubular maximum of phosphorus by GFR. This can be calculated using the formula using plasma phosphorus minus urinary phosphorus into creatinine upon urinary creatinine, or the nomogram, in which once we know the TRP and we know the phosphorus concentration, the TMP-GFR is calculated. The normal TMP-GFR in children is 4 to 8 milligrams per dl, and lower levels are suggestive of increased phosphorus excretion. Since urinary excretion is the major determinant of plasma phosphorus, if the phosphorus levels are very low, below 2, and there is no clear-cut history of nutritional deprivation, one can clearly assume that it is because of hyperphosphaturia, and these tests may not be required. Parathyroid assessment is extremely important in the setting of hypocalcemia, especially if there is high phosphorus levels along with normal renal function, and in any child who has hypercalcemia or rickets with high phosphorus, to exclude the possibility of a pseudo-hypoparathyroidism. Parathyroid is a very labile hormone, and if we keep it in the just the lab and don't process it immediately, there will be a significant deterioration in the parathyroid level, and therefore it should be immediately transferred in ice, and intact PTH measurement should be preferred. The levels of PTH are 10 to 55 picograms per ml, but should always be considered in the context of calcium. So even if we have a normal PTH level in the setting of low calcium, this will be inappropriately low, and they will then indicate hypoparathyroidism. Similarly, a normal PTH level in the setting of hypercalcemia will indicate hyperparathyroidism. So we should always interpret calcium and PTH levels together. So low calcium and low PTH obviously means hypoparathyroidism, but even if the PTH levels is normal where it should have been high, it also means that there is hypoparathyroidism. On the other hand, hypocalcemia with hyperparathyroidism would mean either a secondary hyperparathyroidism in which the phosphorus levels will be low, or rarely this could be pseudo-hypoparathyroidism in which the phosphorus levels are high. High calcium and high PTH levels are directly indicative of hyperparathyroidism. but inappropriately normal parathyroid level for a hypercalcemia when there should be no PTH is also indicative of hyperparathyroidism. So we should be very careful in terms of assessment of PTH level, always in the context of calcium levels. Vitamin D assessment is important in the setting of hypocalcemia, particularly if the phosphorus levels are low and in individuals with rickets. Nutritional status of vitamin D is best measured by 25-hydroxyvitamin D because it is independent of PTH action. It has a long half-life, has a more stable profile, and the effects are not inhibited by the secretion of levels of vitamin D. Levels are 20 to 50 nanograms per ml, which are normal, and in the SI units it's 50 to 150. And there is a huge controversy as to what levels of vitamin D are associated with disease and what level should be considered normal. So when we are concerned about vitamin D levels, we are concerned about hypocalcemia, rickets, high alkaline phosphatase levels, which are indicative of a metabolic bone disease, and hypercalcemia as a toxicity. So alkaline phosphate levels typically start to increase when the level falls below 20, and hypercalcemia happens once the levels are more than 100. So the normal levels are between 20 to 100, and beyond that the level are considered to be toxic. Rickets is unlikely to happen unless the vitamin D levels are less than 15, and this range is considered to be insufficiency, while levels which are lower than 5 will cause hypocalcemia. So levels which are between 15 to 5 are definitely deficiency, and levels less than 5 are severe deficiency. So based upon these clinical findings of ALP, rickets and hypocalcemia, we have categories of toxic levels beyond 100, normal between 20 to 100, insufficiency between 15 to 20, and deficiency between 5 to 15, and severe deficiency below 5. So usually hypocalcemic seizures will happen when the levels are usually undetectable. And based upon that, we have these American Academy of Pediatric criteria. However, recent controversies have been there which suggest that insufficiency may be considered between 20 to 30 and levels less than 20 are deficient. However, there is an area of controversy. Calcitriol levels are required on very rare situations of hypocalcemia with low phosphorus and normal 25-hydroxyvitamin D to differentiate between VDDR type 1 and type 2. Also in the setting of rickets with high PTH, where we are distinguishing again between VDDR 1 and 2 with normal vitamin D levels. Calcitriol levels are dependent on PTH, so therefore the levels may be low, normal or high in the setting of nutritional vitamin D deficiency, for which this is not a good marker. And the levels in infants are 30 to 150 picogram per ml, which are much higher compared to childhood. So calcitriol levels should only be done under special situations and circumstances.